Thank you very much. Thank you very much for the invitation today. So this is going to, so fair warning, this is going to be a bit of a wild ride, okay? Because I decided to go broad instead of very deep. Still, I hope that I will give you enough details for those of you who work in healthcare to maybe check some of our publications if it can be of any help to you, or to at least understand in depth or more in depth what the type of simulations that we do. Just for me to have a sense of the audience that we have. How many of you work in healthcare? So very few, right? So we'll have to go through some of the main concepts. If you don't understand anything, just by all means ask, okay? And I hope that we'll stick to my 50 minutes so we can have a full lunch break. I'm going to talk about, well, let me tell you first who we are and where we are. So we are a group that combines experiments and simulations, and we are part of the WISE Center. So it's the Wellcome EPSSC Center for Intervention and Surgical Sciences. So you are very welcome to come and visit. We're always very glad to have visitors around and to collaborate with people. So we have state-of-the-art facilities in the middle of London. We have a mock AR, a mock OR. We have lots of ultrasound machines, labs, experiments, etc.
Okay. I'm just trying to get these lights off here, but
okay.
I can't work out how to do it.
Okay. And so we have a strong partnership with hospitals in the UK, but also abroad. And yeah, so we have also collaborated with the General Infirmary here in Leeds, with one of the professors here of surgery. So you will see a little bit more about the experimental stuff that we have and the things that we use. But now I'm going to move towards what we call our vision for precision vascular surgery. And this is basically, so we work on vascular problems. So that means we touch everything that is not the heart, although we have done cardiovascular as well. And the whole point is to try to use our tools to bring or to help find the right treatment for the right patient at the right time. So this won't be a surprise to you. This is one of the tenets of personalized medicine. And essentially, we want to help clinicians to pre-op, to plan better their operations that they're going to do or the interventions on patients. And that's the first part of my talk, these short-term solutions, right? But we are interested as well. So I did my PhD in applied mathematics, actually, and I'm interested in what happens in the long term. And this is going to be a back and forth all the time, thinking about we're solving this immediate problem, what's going to happen in the future, because this is what happens in the mind of the clinicians. They have a problem to solve, very much as engineers. However, the problems that they solve now can create a lot of problems in the future. So how can you solve the problem now whilst minimizing the problems that you will get further down the line? And believe me, you will get them. An operation or an intervention is an incredibly brutal, aggressive intervention. So our bodies cope with it, but they also react to it. So I'm going to speak about first. So this is the summary. So we work with in vivo, so with clinical data. So that was captured in the hospitals, so either CT, MR, ultrasound, and we incorporate them or we use them to inform our CFD models, and then we will use those models to plan those interventions. So this is what we call hemodynamic prototyping. So you try to optimize the intervention from a hemodynamic point of view. Then we are trying to incorporate some elements of virtual reality into the platform that we have, because we also have an element of, so we also have a fluidics platform where we can test the interventions that we calculate in Silico. So we use the computers to picture some scenarios and do some calculations for the clinicians, but then we can test them in the lab, and I will show you how. And then we are incorporating some elements of virtual reality into that as well. So what we do is that, as I said, we use modeling and simulation to try to help sort out the short-term problem, but we also try to imagine what we can do to look at these long-term predictions. And so I'm going to speak about two examples. One of them is going to be aortic dissections, first because they are complicated. The second one is because we have done a lot of work on them. And the third one is because they encapsulate a whole range of vascular problems, extremely complex to tackle from a CFD perspective. So I would say conditions of the aorta, there is nothing more complex than this. So, and then we'll talk about the case of neo-intimal growth for peripheral arterial disease, and that is the long-term prediction. So they are not necessarily linked one and the other. So this is not a short-term solution for aortic dissection problems and the long-term prediction for aortic dissection, but I'm going to show you what kind of tools we can maybe use to look at vascular remodeling problems. So example one is an aortic dissection. So an aortic dissection, you have a tube that is the aorta, that is whole. It has three main layers, intima, media, and adventitia. What happens is that you will have a tear and you will have blood flowing into the media. And then this will eventually create subsections, or what we call a false lumen, a big aneurysmal region. Okay, and then this is linked to certain conditions. So you have the false lumen, and then the true lumen. So the false lumen is the dissected region, the new region that was created. The true lumen is the region that was there before. So the tube that should have been there. The causes are high blood pressure. So chronic hypertension is an indicator or a risk factor for aortic dissections, and then higher stress, higher blood volume. So when women are pregnant, for example, they are more at risk of a dissection, and coarctation. So that means a narrowing in the aorta, because obviously that creates a block and that creates higher pressures, right, before the block. So you have two types, type A and type B. Type A are in the ascending aorta, and it's a critical medical emergency. There is no time to simulate anything. In that case, the patients, they have to go immediately to the operation theater and they have to be intervened on. And then you have the type B dissections, that is basically everywhere else. But I'm going to show you what everywhere else looks like and how each dissection is different and how complex they can be. So why is this not moving? Move. Anyway, so I'll show you the type B later. So for the case of the aortic dissection, so we imagine that first the patient will have an assessment and they will have an intervention with a personalized device, let's say. Okay, so you might decide to stent, to put a stent graft. Stent graft is essentially a piece of tube, so you cut. I don't know if any of you who have been or who work in healthcare have seen one of these operations. They essentially make a massive cut either on the side, or sometimes they have to cut to operate and to open the sternum and to try to access the aorta. And then you will have they will cut, so they will clamp, they will perfuse the rest of the organs, because it's an operation that takes a long time as well. So they will cut the aorta in the places where they think the stent should go or the stent graft should go. They will patch it, they will do some surgical sutures, and then they will patch up the patient, and off it goes to critical care. Right, so then this patient, in an ideal world, okay, so something I didn't mention before is that as the type A's are a medical emergency and you have to intervene on them immediately as soon as people come, and dissections are relatively rare, but not as rare as people think, because they kill more than road traffic accidents in the UK, more people than road traffic accidents, right? So as for the type A, they need to intervene on immediately if they manage to acknowledge or to see that it's actually a dissection, because the symptoms are a bit confusing and they resemble many things. Then what happens is that there is no time to think. They just go and do their thing. So they do a replacement and they try to address the issue immediately, because otherwise the dissection can go towards the valves and towards the heart, and then it becomes completely catastrophic. There's nothing to do there. Okay, now with the type B's though, the situation is a bit different, because there are two approaches. One is the interventional one, where they will say, well, we're going to put a stent or a stent graft, and we're going to put a medical device inside this patient, or depending on the dissection, they might just say, we're just going to wait and see. We're going to control the blood pressure always, because hypertension is a risk factor. And then they will say, we're going to wait and see. And the wait and see process between when the patient comes to when they decide what they're going to do, if they're going to do a personalized implant or not, etc., it takes about a couple of months for people sometimes to be intervened on, because it can be controlled. So as long as the patient is well controlled, they will hope that the dissection will naturally completely thrombose, and that means that the blood inside will solidify. So you won't have the problem of the dissection before. You won't have the flow going in. Essentially, it will sort itself out naturally. That is the best possible solution. It doesn't always happen. So we can do an intervention. So we can do a simulation, just where do we stand, how do we stand, where do we put the graph, how long should it be, etc. And then we present different scenarios to the clinicians. Then we go to this physical testing platform that we have, that I'll show you in a video later, where you can actually test some of the interventions. And that is quite powerful, because I always say to people think, the clinicians, we know everything from imaging. Well, no, you can't, because images tell you about the present. What you want to know is the future. That's why you're using CFD. So they cannot tell you anything about the future. They tell you what is happening to the patient now. But then how do we bridge that gap of realism between the simulations and what the clinicians experience? And that is the next step. So we imagine that we could use something like this, like the things that I'm going to propose today. And we are trying to get into conversations with medical devices manufacturers. The Aortic is one of the main ones for dissected aortas, where they could imagine, we are trying to see how they can incorporate some of these elements in their manufacturing workflows. And then, of course, once you do all of that, then you can do some in-depth quantification, look at some variables of interest to them. So one of the key variables that they look at is how big is the pressure in the false lumen, how are the pressure fluctuations in the false lumen. So in this part that is very diseased of the aorta. And there are other markers that they do not use clinically, but we all know that are linked to vascular remodeling. So for example, washer stress or OSI, so higher levels of oscillations and low values of shear stress. Also higher residence times, for example. They don't use them clinically, but that doesn't mean that in the future they might not. So I'm taking a long time to go through this, and I have a lot of slides. So I'm going to try to hurry up. So I'm going to present you what we can do with routine datasets. And these are 3 patients from one of our collaborators' hospitals in Rome. And the patients, we had very few, so we had what is collected routinely, plus some extra data collection done for validation purposes only, right? So we are not, in principle, to set up the simulations, we don't need the invasive pressure measurements that were taken, but we use them as a validation for our models. And this is the publication, if you're interested in. So the presentation is being recorded, so I'm just putting relevant publications there. Very happy for you to contact me otherwise if you have any questions. So these are 3 dissections. You can see how different they look. We use a software called ScanIP to segment and to reconstruct these aortas. And these are very complex cases. And I'm doing a zoom in here so that you can see that there are many different communications between what is called the false lumen and the true lumen. Before I show you this cartoon, this schematic of, oh, there is a tear and it goes there and it forms a big aneurysm. Actually, the dissection can go anywhere. It can expand into your renal arteries, into the iliac arteries. So once it starts, you don't know where it stops. Okay? So, and you can have many what we call fenestrations, so these communications between the false lumen and the true lumen, which actually make the fluid dynamics understanding for the clinicians, what do I do with this case, very challenging, because as we all know, fluid dynamics can be incredibly counterintuitive, right? So it depends on the boundary conditions that you use, or actually the condition of the patient, and in your models of the boundary conditions that you use and how you model certain things, right? So so you can see there the level of complexity, and no two dissections are alike. And this is always the case. They are poorly studied in medical schools, so they don't have a lot of, so they learn by doing when the clinicians or the surgeons go into their specialism. And they have to learn one case at a time. And they lean on a lot of experience and expertise, but this is very, very difficult for example, a registrar that is just coming into commanding a complete ward on a Saturday night, for example, to tackle, right? So they will call the consultant for that. So what does the CFD simulation in this case is? So we use for this case, because we had very limited data, right? We use a rigid wall simulation. It's not what we normally do, but this is as much as we could, I mean, as far as we could go with the realistic assumptions. I mean, quite frankly, if I give you 2 points on a graph, I tell you fit a curve, the best. You can fit whatever you want, but honestly, a straight line will do just fine, right? So we use a rigid wall approximation, but we use for the boundary conditions what we call Wink-Kessel models. So Wink-Kessel models are a combination of resistance and compliances. So if you think of a capacitor, for example, so you will have a change in the pressure with respect to time that corresponds to the storage of the aorta in those vessels, for example, and then resistances that reflect the viscous resistance of the flow and the terminal resistance in the small vessels. Okay, so then we used a software, so we don't use OpenFOAM, we don't build our own software. We have scripts, of course, and we use our own software in combination with CFX and now Fluent, but we use software that is already there, and we test the limits of that software thoroughly and robustly. And for this case, we use laminar flow, and it's a transient simulation, obviously, and a non-Newtonian Carroyer pseudo model, which is standard in the literature, with the parameters that we obtained from a paper that is very well known from Gibson. So the inlet flow rate was adjusted to the patient based on the heart rate and the stroke volume of the patient. So that means how much has been the heart is ejecting and how much the heart rate is. But we didn't have a flow pressure curve. So we had to impose, in this case, it was not even parabolic, it was just a flat profile. There is absolutely no point, and those of you who are working on valves, right, you will know that the flow coming out of the aortic valve is neither parabolic nor flat, right? It can have lots of shapes, but quite frankly, you're pushing a lot with a lot of force, so there is a big inertial element there. So we thought that the flat velocity profile coming into the aorta was as good as, as we could with the information that we had. And just to give you some, so I have some notes here in case you were interested. So the Reynolds numbers were from about 600 to 1500, Wormersley number between 20 and 32. And what else did I have here that you might want? I think the rest we can discuss separately, right? So CFD results, what we calculated versus what the clinic gave us. So remember that we had some invasive pressure measurements. This is not usually done. It's impossible to do here in the UK. So they did it with these patients in the hospital. They tried to not put catheters inside these patients, or also to try to measure the pressure in the false lumen is very tricky, because obviously you don't want to puncture, you don't want to break the false lumen as well. So it's incredibly it's really frowned upon. And so when we did our calculations with the assumptions that we had, we actually got a good match between the pressures that we could calculate and the pressures that were given to us. And imagine how this data is given to us. There was a drawing of the dissection, right, from the clinician, and they said, we measure pressures here, here. Okay, and this is about this way, this is here more or less, and this is here more or less. So we had all those pressure measurements dotted around the aorta that we kind of had to second guess where they were. But in the end, we managed to get a simulation that was coherent, and we were able to give them some results, like the results that I'm presenting you here. I mean, if nothing else, quite frankly, we're working in fluid dynamics. Pretty pictures are the name of the game. I can give you as many pretty pictures as you want, and I'm pretty sure that you show them all in your own presentations. But these are the type of things that we can calculate. So they're interested in pressures, as because it's a main marker for progression of these dissections, but also we can calculate things like taus and OFTI that might be interested to them for them to think about what might happen in terms of vascular remodeling. And I'll show you an example on another case, not this one, of how that can be of use. Right, so you can also plot the difference in pressure between the false lumen and the true lumen, because you might have a false lumen that is completely, or that might try to push entirely into the true lumen. For example, that might just restrict the blood flow going into the rest of the organs, for example. So, but remember, these simulations are rigid. Okay, so everything that we say here and that we said to the clinicians, they had to be taken with a pinch of salt. Okay, now what happens if we have rich data sets? And this was captured here in Leeds at the Royal Infirmary, at the General Infirmary in Leeds. And we had a case of a dissected an aortic dissection, again a type B. This was a 77-year-old patient. This was already captured quite a few years ago, where his dissection had been going on for decades, okay, and never thrombosed, which is a bit surprising because this dissection is possibly the simplest dissection that we had, and it's only 1 in 3 tear and no exit tear. So essentially it's a big aneurysmal sac. You have the compliance of the aorta, okay, so you had your aorta pumping. They had this patient on medication and controlled blood pressure, and but it never thrombosed. Might be a combination of the structural elements, right, of how this dissection is, and the fluid dynamics, and also the medication that this patient is given, okay? But it never thrombosed. So we had CT scans, and we used the CT scans, so computed tomography. So this is highly resolved. So we use them to actually extract the geometry of these dissected aortas, and then we used MR. So for those of you who don't know, I won't go really into the details, but MR can give you movement, so that's cine MR, and I'll show you what cine MR looks like in a second, but it can also give you flow. So it can also give you some planes. If it's 2D MR, if it's 4D MR, it's different, but if it's 2D MR, which is the one that we had, you just get flow on certain planes. So you get pixels with different intensities, you know the encoding velocity, so you essentially know for each one of those planes what the velocity is at each point in the, in the plane that you're looking at. And then we had some pressures, okay, along the arm. So when Mustafa and your other colleagues contacted me, they said, well, we will be interested in FSI. And I was like, no, I'm not going to talk about FSI. So you can do FSI. We have done FSI on these aortas. However, the truth is that there are no good pathological models of tissue, or there are no good models of tissue that represent the pathological case that is a dissection, right? So even representing normal tissue is a challenge. So we went to Yale University about a month ago, and we had a discussion with Jay Humphreys. Some of you might know him, some of you might not, but he is one of the top researchers in the field, okay? And he used to work on dissections, and he told us, I'm actually looking for a simpler problem from a tissue mechanics perspective, because we simply don't know enough about the characteristics of the tissue of these dissected aortas. And also we don't understand. Once we think that we know what's happening to them, when you try to replicate or to understand what happens to them, it goes completely mad, okay? So you would think, why is this reacting this way? Why is this flap, this division between the false lumen and the true lumen working in this way? There is no rhyme or reason to it yet. So that doesn't mean that when I retire, some people might have some good answers to that, but there isn't. So in the end, what we were interested in was really the hemodynamics. So we didn't want to know about tear propagation, for example, which is a hot topic. There are no good models of tear propagation. So we said we're going to come up with an alternative methodology. And we came up with a moving boundary method, where we have an implicit two-way coupling between the boundary motion and the fluid dynamics. And we displace the mesh nodes based on fluid forces inside. It's actually quite simple. because what we say is that the displacement will be a calculation, and this is done on every node on your domain. So you will have your domain discretized and you will have your mesh. So along the domain, we will calculate this displacement based on the internal pressure, the external pressure applied, and a stiffness coefficient that we tuned with Cine-MR data. The Cine-MR data that we had for this patient was quite rich. So we knew at different planes how the aorta was expanding in different sections and how it was relaxing. And then you can link your stiffness coefficient to the areas, each area for each one of those planes. And then what we do is that we interpolate between all those values to get some continuity. So all of this is described in the paper that I'm going to show you now. And then we have a complete map of how the aorta moves. There is no movement that is imposed. It's all calculated from the simulations. And now we have these complex complex simulations, CFD simulations, where you have a complete map of how the aorta or the stiffness of the aorta or how flexible this aorta is everywhere, that you can now couple with fluid mechanics models that are also quite complicated. But at least these are tunable, entirely tunable to the patient based on imaging modalities that are used right now in the clinic. So we did some comparisons between the two PCMRs, so the flow MR that we had and the calculations that we did. And so this aorta is now compliant. So just to be clear, right? So this aorta is now compliant, and we have these boundary conditions that are also representing expansions and contractions, right? So this is far more advanced than the models that I presented you before, but it's because the data allowed us to do that type of models. And we compared, and we saw that actually our calculations were quite good when you compare to the MR data that we had. So this is what a Cine-MR looks like. So it's the one at the top. Does this work? So this is Cine-MR, right? So you can see the flap. So there is this intimal flap here. So this is the false lumen and this is the true lumen. You can see it from another angle here. And you can, so you can see that for each section. So if you split this into planes, then you can see how much this expands or contracts, and it's basically, and it's all being tuned based on how much the area is changing for each one of those planes that we actually mark on our software. And then we did some comparisons between rigid wall simulation models and this model that was already quite, well validated, if you like, because we had really good data sets and we knew that our simulations were really on target. Now, there is an interesting thing here. So this actually tells you a little bit of how important boundary conditions are in this case. Remember that I told you at the very beginning, if you haven't lost you yet, that this patient had been living with this dissection for a very long time and he had never thrombosed. So if you look at the plots that I'm showing there, what you will see is that the rigid wall approximation predicts zero flow going into the false lumen. There is no flow. I mean, it's rigid. Where would it go? Once you have the fluid there, even if you have a lot of pulsations in the aorta, I mean, where else would it go, right? So it predicts zero flow. When you use the moving boundary method, you still have a flow that wasn't captured before. Also, the dynamics of what happens with the pressure and the in the rigid model and in the compliant model are different. So you can see the compliant model, the true lumen in the true lumen, the pressure is higher for the first part of the cycle, and then is the false lumen one, right? Marginally, but yeah. And in the other case, it's very different. But we do have a prediction of flow going into the false lumen. Now, does this explain that this was never thrombosed? Not really. Can this be an element? Maybe. Okay. So, and obviously we can do the pretty pictures again, and then I can show you all these hemodynamic markers that might be linked to disease progression later on. They are of no clinical relevance, so I'm not going to discuss them right now, but obviously this is the type of analysis that you can show to the clinicians, and then you enter into interesting conversations about what is going to happen to these patients and so on and so forth. But I will tell you more in a different example that I have. And this particular patient and this model was published already a few years ago, and it's an interface, so it's open access. You can, if you're interested, go and have a look. We also put as part of the paper the geometry, and I think we even put the mesh, so you can download the whole thing except the modeling, which is ours. Okay, so you can download at least the geometry, and then you can see how you fare if you're trying to apply some of these methods compared to what we had there, because replication of results is an issue in this area, as we all know. So we just try to be as fair and square as we could. Right, so now what happens if I tell you that now we have the same patient, but in vitro? So we produce, and the results that I'm going to show here first are going to be with rigid phantoms, but we have now results with compliant phantoms. So we replicated, so we produced this replica of this disease aorta for this patient, and we put this into an experimental setup that we designed entirely from scratch, so it's entirely ours. There are details published in the literature as well. I forgot to put the paper here. But we have essentially so we have a pulsatile pump that can replicate a patient-specific curves for the inlet boundaries, inlet boundary condition. Then we have wing Kessel models, so this combination of resistances and compliances, and we can add as many as we want. So these are physical models that we have there that replicate what we do with the calculations. The 3D, so the 3D printed aorta. And then what we do is that this is work that I'm doing with, I'm a numerical, I'm a modeler, but I work very closely with my colleague Sabrula Balabani, and she's an experimentalist. She works on PIV. Some of you might be using PIV. So we seed the flow with fluorescent particles, and we put a laser through, we take a lot of images, and then we see how those particles move. And then we calculate the displacements and the velocities, really, of the velocity fields inside. So this is what it looks like. So we have the pulsatile pump. These are two mechanical heart valves that we got from the hospital. So this is the heart. Then you have the aorta. Okay, in this case, it's 3D printed. When we moved into compliant phantoms, they are not going to be 3D printed anymore because we couldn't. And these are the wing Kessels, the ones that you show. And then there is a return towards this reservoir that acts as the atrium, and then the cycle continues. Okay, so now we have in vivo data. We have an in vitro setup that we can test, and we can also have an in silico model of this aorta. And we did some comparisons between PIV and CFD, and the comparisons actually, they stack. Okay, the comparisons are good. So I'm showing you the normalized velocity on those planes. So the normalized velocity and the normal velocity on those planes. And the comparison between the PIV, this is not volumetric PIV, so this is 2D PIV. We compared along those planes that you can see there, and those planes, some of them capture the dissection, and some of them a little bit before, a little bit after. So I'm showing you 2 times in the cycle. So ascension, so towards peak systole, which is the bottom part, and then I'm going to show you diastole, which shows a much more disorganized flow, and we still managed to capture a lot of the complexity of the flow, a lot of the complexity of the velocities of the velocity field in that case. So this opens up. So this paper was published in 2020. So the paper is here. If you want the details, this paper opens up a whole load of possibilities for us, because essentially now we can say, fine, we have demonstrated that in principle we can do this. So now what happens when a clinician comes and we can do these potential interventions for them in silico, in the computer, but then test the ones that they are interested in the lab? And it's a completely different ballgame. I mean, we're not there yet, but you can imagine how this could be potentially used, maybe when I'm retired after, okay? How this could be potentially used to treat patients. Now, where are we now? We have compliant phantoms now. So these compliant phantoms, they capture, it has been a challenge to say the least. I don't even want to go into how much time we have spent producing these phantoms that are compliant and transparent, and that match the refractive index of the fluid that we're using inside, but we managed to. And these are phantoms that are now comparable, so they have very similar young modulus to aortas, right? And we compare to this distensibility matrix or distensibility map that we had of the aorta that I showed you that had all these colors, so how much or how compliant this aorta was, and it actually compares quite well. I don't have the results yet because we are in the process of producing the figures of doing the comparison between PAV measurements and the displacement of the boundaries or the, so how compliant the aorta is and how much those boundaries displace to compare to our own simulations in detail. So this is hot off the press, really. And we have new methods also to extract three-dimensional velocity fields. Now, I showed you results before with 2DMR, and now we are getting really good data sets. I mean, these are really fantastic data sets from our collaborators in Bern. And we can now model these disease aortas in a level of detail that so far we haven't seen in literature. And this is the work of one of our excellent PhD students who took these disease aortas, but also included a lot of the small arteries that are at the back and that feed a lot of your spine, for example. So these are called the segmental arteries. And although one big assumption in the literature, and we're challenging that assumption right now, is that it doesn't really matter because they are so small that, you know, it doesn't really matter. I mean, when you cannot measure anything, you can say anything, right? So, but now we can measure it. And the truth is that there are still big assumptions behind, okay? So what we're saying is you cannot generalize. For some cases, this might be the case, but for some other cases, it does matter. There is a non-negligible amount of flow that actually exits the main aorta that we usually correct for when they don't exist, these segmentals in the previous models that I showed you, right? But that affect also those values like wall shear stress and oscillations, right? And also some patterns close to those bifurcations or those exits, okay? So we are not saying that this is the end. We're not saying that there's nothing else to be done. What we're saying is be careful with your assumptions because a big assumption in the literature does not necessarily hold and we can do better, right? So, and this paper has already been published. So in Annals of Biomedical Engineering, and it was in March this year. So you think you solved it, right? So think again. We're now going to be moving on to this, what happens with in the long term, right? Because I've been showing you how to patch patients. How do we do? This patient has this. Well, we're going to do that, and that's it, problem solved. Well, not really. Look at this case, for example. So I was looking yesterday at papers where they were talking about complications. These patients, they have one surgery after the other. I mean, that's the life of these patients and the life of many patients that undergo vascular interventions. There are many things that go wrong along the way after many years. So look at what happened here during follow-up. So there are a lot of things that happened to this patient. There was a replacement, a valve replacement following a dissection. So there was a type A dissection. But what happened was that there is now a dilated aortic root and an endoleak. So that means that whatever they put there now is leaking. So that is a problem because it can create still this big aneurysmal region, right? It can rupture. Okay, and a complex reoperation was required. So you sorted out the problem 20 years ago for this patient, and this patient keeps coming up because there are things wrong still that are the consequences of the decisions that we made 20 years ago. So this is vascular remodeling and reconstructed aorta. So this is data. So we haven't looked, I mean, we are preparing the paper now, but this is data again from Bern, where we had MR from a patient between 2021 and 2022. And we observed an enlargement of the aortic root and the ascending aorta that was quite significant. They did notice it, but they didn't consider it troublesome, right? However, we did some preliminary simulations. So they were looking at the stent, right? So you didn't see it here, but actually in this region, around here, there is a stent, okay? So this aorta was reconstructed. You don't see the false lumen and the true lumen. This looks like a normal aorta now. Now, what we noticed was that there was a lot of flow going back through the aortic valve, through our simulations, which they didn't pick up, and a lot of recirculation, lots of vortices here. And vorticity and regions of low shear are linked to aneurysmal expansion. Okay, so endothelial cells, they don't feel the mechanical stimuli that they should, and they start misbehaving. Nobody really understands how this happens, but they entirely miss this. Okay, so we reported back to them. We don't know who this patient is, but we said, have you actually had a look at what happens not in the stent, which you were checking for endoleaks, but what happens in the aortic root before? And close to the aortic root and the ascending aorta, and they said, okay, we need to have a look again, and we need to recall this patient to have some more detailed investigations. So we don't know what happened, but we thought that this could be a really nice paper for a case report in one of the clinical journals about using CFD to help clinicians maybe assess patients. Right, so now let's talk about example number 2. And this is another type of vascular remodeling. And this is what we call NIH growth. So NIH stands for neo-intimal hyperplasia. And what happens, we're going to be looking at this in the lower limbs now. So if you go to the NHS website, they say if you have peripheral arterial disease, so that means that you have atherosclerosis in your legs. And if you don't know what atherosclerosis is, it's just the hardening of the arteries due to fatty deposits inside the arterial wall. And there is some fibrosis as well. So essentially they rigidify, but there is an accumulation of lipids inside as well. And if you want to look at it from a fluid mechanics perspective, what happens is that, well, that plaque can become unstable. So we also call them plaques. They can become unstable and detach, and there is a whole load of problems with that. But essentially they restrict blood flow because the artery becomes narrower and narrower and narrower. Okay, so they say in the NHS website, in some cases, you will have to go for surgery. Well, now, I actually challenge you to speak to your, if you have any vascular surgeons that you're friendly with, how not often this is the case. There are more than 260 million people worldwide with severe peripheral arterial disease, and the vascular clinics are completely swamped now. They have no time. They have so many patients that they have no time between one patient and the next. And what they do is that they, you can do two things. Either you do a balloon angioplasty, so you put a catheter, you inflate a balloon, you open up the artery, put a stent to keep the artery open, right? Or you do what we call an autologous bypass. So you use one of the veins to bypass the region that is being restricted to restore blood flow, okay? The name of the game here is to restore blood flow, okay? Just as in most vascular conditions, when you're tackling a problem, what the clinicians want is to restore blood flow and to restore function, okay? Now, what happens is that you have a lot of inflammation, okay, when you do this. And nobody really understands why the vessels will keep on narrowing and narrowing. So you open them up with your balloon, you put a stent. 6 months down the line, maybe, the patient will come back and it will have a narrowing again. And there is only a limit as to how many stents you can put in. A stent is not a stent, okay? So we need to really understand why this happens for some patients and not others, okay? So why are we using mathematical models to do this? Well, because animal models have utterly failed to address this problem. There was an editorial a few years ago saying something like, and I'm paraphrasing, but I'm not too far from what they wrote, that 5 or 6 decades of high-power vascular science have completely failed the field because we have no clue as to why this still happens. And the first implant was done 70, 80 years ago, the first bypass, and it's still a technique that is used again right now. So we think that we can use mathematical models to try to understand the complex dynamics between what happens with the blood flow, the endothelium, and then what happens inside the arterial wall. And so I'm almost 50 minutes in, so I don't want to run too much. So this part of the presentation is shorter, but in essence, what we do is that we get CT scans and Doppler ultrasound. And if you have been working with Doppler ultrasound, you know how good the data is, but nevertheless, that's the data that we have. And then we have data pre-op and post-op. So we know in the case of an implant or a bypass or a stent, what the data is. In the case of the bypass, sorry, in the case of the bypass, you only have the bypass. I mean, you do nothing with the geometry before the bypass, but then we can have some follow-ups after to know what happens to that bypass along with time. And then we have a mathematical biology model that relies basically on mass transfer concepts and mass kinetics, and is essentially we try to identify main cells that would react to mechanical stimuli on the wall, and through mechanisms. So some people, so there is some evidence in the literature that there is a link between nitric oxide and how starved those cells are of oxygen, and the production of more cells that actually can create this growth. Okay, but in essence, for this research that for this paper that I'm going to show you now, we have 3 patients that we obtained from the Veterans Hospital in Yale in New Haven, and we have again our models. So the postulate here is that we said, right, so everybody looks at this in silos. We're going to try to put things together, and if we really want to understand what the relationship is between fluid dynamics and what happens inside of the arterial wall, first of all, we need to have a good first model of fluid dynamics inside that part, right? So I think it stands to reason. It seems a very sensible thing to do. So we have, again, just as we did with the aortas, I'm not going to a great level of detail here, but it's patient-specific anatomical details, boundary conditions, and flow models that are similar to the ones that we used before. And then for these cases, they are rigid wall simulations because these bypasses, they tend to rigidify actually at the levels of pressures that they're subjected to. They are veins who have to undergo a dramatic process of transformation to become arteries in a sense. So you explant, you take these veins from their natural environment and you subject them to high levels of pressure and flows, which they are not built to. So either they adapt or they're dead, right? So but they do rigidify. So we use a rigid wall approximation for this. And we couple this with a mathematical biology model. So essentially, what's happening to the smooth muscle cells, and what's happening to the collagen inside, and what happens to the growth factors that they have, and what happens to, at the end of the day, we managed to come up with equations that calculate the volume on that wall and how it grows based on the number of cells that you keep on producing that will produce this growth. So, and there is a link between nitric oxide and the growth of those cells, and that's the link. That's how we link the biomechanics or the blood flow and the rest. And this is essentially the process that I told you before. And what you need to imagine here is that you will have, the more vascular remodeling you have and the more the lumen narrows, those hemodynamic variables will also change. So it's a dynamic process. But it's also a multiscale process. It's also a multiscale problem because you have blood flow running in seconds, cell turnover in seconds or even less than seconds, and then you have vascular remodeling that happens in months. So some results, and this is really the end because the next is a summary slide that is very short, is that we managed to actually predict those locations using a combination of so this mathematical biology model with a modulated shear stress. So we had taus as part of those equations that was modulated by oscillation, so OSI. And we managed to predict regions of growth much better than using the standard approach, which is only relying on either one or the other, OSI or time average wall shear stress. And this paper is also out. So, well, the results are very good. So I'm very happy to just to not talk about them in the sense that we know already that we predicted the areas of restenosis or the areas of neo-intimal growth very close to what the CT scans told us it would be. So this is a model that we set up at 0 time, let's say. So just after the bypass, we said, model, you go and run. And we're going to see in simulation time what happens 6 months down the line, which is one of the time points that we had for our simulations for the patients, right? So we have 3 6-month cycles. And the truth is that we managed to predict within the time frames, a matter of a few days here and there, how much the growth was and how much the narrowing was for each one of these patients, 3 patients. So I'm only showing you here. So the detailed simulations that I had before. Is this the end of the story? No. Okay. I mean, do we need more patients? Sure. But it's interesting at least. And it gave a lot of ideas to our vascular biology collaborators in Yale, because then they said maybe we should really include some studies on the endothelial response to shear stress into the models that we have, the mice models that we have. Anyway, this is really the last slide, and this is for you to consider. So to consider that we as engineers can help clinicians to design anything we want, but you solve the immediate problem and the long-term problem remains. How do we go from one to the other? And the tools that we have now are fundamentally inadequate to actually tackle this, but we can try, right? So we can try to improve the tools and build more multi-scale models, try to couple, but the whole point of this is that if we keep studying things in silos, we will never really get to the bottom of this vascular remodeling problem. At least that's my belief in any case. So thank you to the people who actually make this happen. I don't do the simulations anymore, sadly, because I really like doing the simulations. So I have to tell you, I'd rather do that right grants, but never mind. And these are some of the people in the team and the collaborators that we have. So I know I've overstayed my welcome here. So it's more than 50 minutes. Well, thank you very much. And if you have any questions, you can ask now or during the lunch break. Thank you.